From Redfield Medical Direction, I'm Lynn Wynn, Associate Medical Director, and this is our EMS Podcast, your link between protocols and practice. All right, everyone. Today we're going to be diving into a topic that every EMS provider will face: patient refusals. Almost a tenth of EMS calls end in a patient refusal. And so we're going to focus on a subset of those cases, the high-risk refusals. And by high risk, we're not talking about the stubbed toes or runny noses. We're talking about the acute chest pain, the stroke symptoms, the altered mental statuses, those refusals that can feasibly end in a bad outcome for the patient. So, Dr. Redfield, when is it okay for our medics to let a patient refuse, and when would you like for them to have us step in?
Let's first define high-risk refusals. This is when a patient has a potentially life-threatening condition but refuses treatment or transport. We're talking about the classic chest pain patient who swears it's just indigestion and they have a massive STEMI on the 12th lead. Or the patient with left-sided weakness who's awake and alert, but they just don't want to go in.
So in both those examples, the heart attack and the stroke, there's a mantra that time is muscle or time is brain, depending on what's going on. So if there's any delay in getting definitive treatment, the risk of death and permanent disability just keeps going up.
Yes, and not to mention the legal risk behind all of this, because if we walk away and something bad happens, people will be asking why we didn't insist on transport. That's why EMS providers need a solid understanding of who can actually refuse and how to document it appropriately.
Okay, so before we accept a refusal, we have to ask, does the patient actually have the capacity to make this decision? And I want to take this opportunity to clarify the difference between capacity and competency, since I even hear hospital staff and doctors even use the terms interchangeably, and the two words have very different meanings. Capacity is what we use to describe whether or not a patient can understand their medical condition, as well as the risks associated with refusing treatment. We might not agree with their reasoning as to why they're refusing transport and treatment, but they're at least able to describe their own logic, however flawed it might be. This is exactly why sometimes if you get me on the med control call, you'll hear me ask the patient, why do you not want to go to the hospital? It could be something like they just had a bad experience last time. Is that a good reason that I agree with? No, but it's a reason that is motivating them. Competency, on the other hand, is a concept used in the court of law to describe whether or not a person has the mental capacity to participate in legal proceedings or be responsible for their decisions. There might be some overlap with medical capacity, but it's not a term that we should be using in our field or documentation.
Right, and the capacity comes down to four main things. First is understanding. Does the patient understand their condition and why EMS was called? Second, appreciation. Do they actually recognize the risk of refusing the treatment? Then reasoning. Are they making a logical decision or are they impaired? And last thing is the expression of choice. Can they clearly and consistently communicate their decision?
And there are some situations where it's not as clear cut, such as when the patient has had a couple drinks or their oxygen saturation might be sitting at 90, 91. They might be days since they hit their head. And at times like that, the capacity just might not be as clear. So, Dr. Redfield, say you got a patient with a chest pain and they've got ST elevations in the inferior leads, reciprocal depressions, and they say they don't want to go to the ED. What's your next move?
First, I start with tactical communication. Instead of saying, you really should go, I say, can you explain to me what you think is happening? What do you think could happen if you don't go to the hospital? If this is a heart attack, waiting could be deadly. Are you willing to take that risk?
So by asking those questions, you're kind of covering those tenets of capacity that you just mentioned. Essentially, you are trying to get the patient to say in their own words what they think is happening to them, that they understand the risks associated with their condition, as well as the risks associated with not getting transport and treatment. And sometimes it's just nice for them to hear it from another person that they should go.
And I think that's a great approach by getting online medical control. Getting somebody else involved is key in these high-risk refusals, and that typically is your medical director who you can call for online medical control. This is your best friend. Studies in the past have shown getting a physician on the phone talking to the patient can convince the patient to go a significant portion of the time.
And after calling the medical director, you got to make sure that you document that you talked to one of us. and document your exam of the patient and your assessment of the patient's capacity. Stating patient A&O times 4 refused is just not enough.
That is correct. A proper high-risk refusal must include 2 complete sets of vital signs, blood glucose, and an ECG if indicated. A detailed capacity assessment is warranted in the narrative. The risks explained to the patient, who you contacted, family, law enforcement, medical examiner, etc.
And if you're ever doubting their capacity in the event that their oxygen is just a little low or they seemed a little too dazed for a little too long after hitting their head, just err on the side of patient safety. If needed, involve law enforcement to help with any sort of involuntary transport.
Let's hit the big takeaways today. First of all, not all refusals are equal. High-risk cases need extra caution. Assess capacity. Look for intoxication, confusion, or medical issues can impair patients' judgment. Use tactical communication to help persuade patients. Call med control. It protects you and may help the patient be transported. Document everything. If it's not written, it didn't happen.
And that's all we have for this episode. This podcast was written by Dr. Redfield and produced by me, Lin Nguyen. Our theme music is from Infraction. As always, if you have any questions, don't hesitate to reach out. See you next time.